also thank the organizers for inviting me. I was asked to talk a lot. I hope I'm not boring you. But you'll see a lot of the same themes, and I just wanted to highlight what I think might be some of the next questions we have. This session was really loaded. I'm not sure what I can add at this point. You saw a lot of different things covered, and again, there's some definite themes here. So what else is on our minds? I think, can we better risk stratify our patients at diagnosis? What do we know about cardiovascular risk? That's definitely a theme, and what can we do about it right now? How do we choose in the U.S. the patients for TFR? We had a very nice presentation by Professor Hughes on his thoughts, and can we better predict TFR success rather than a coin toss, which I think is what we'd probably tell a patient it roughly is now. And what about second treatment-free remission? What happens to all those patients who might try and fail and be under a fair bit of stress with restarting TKI? So quickly, risk assessment, I think, and Tim, please correct me if I'm wrong, this is your group's data, but I think we saw some very nice data presented on germline variants predicting imatinib response and risk of failure. So ASXL1 and BIM, germline variants have been now appear to predict response and risk of failure, particularly with imatinib. BIM, the story is not new. It's a pro-apoptotic member of the BCL2 family, and polymorphisms, which are more common in the Asian population, have been cited as a cause of imatinib resistance. And then the postulate here might be that the variant might lead to different mRNA function and splicing, and might clearly be something to go forward with further research. ASXL1 is an epigenetic regulator, pretty widely known in myeloid malignancies if there's a mutation to be generally adverse risk. And this is the function is binding to a repressor complex, and downregulation of ASXL1 would be not advantageous, and that may be the way a variant in this case could be affecting patients with CML. So the data is, if you look, this was in patients with both imatinib and nilotinib, and if you looked at deep molecular responses stratified by the genotypes of ASXL1 and BIM1 for these variants, there's clearly a pattern of the different variants that is statistically significant. And in univariate and then multivariate analysis, looking at so-called risk score, which we know is predictive in these variants, you can see how it predicts not only for early molecular remission, but molecular remission over time, major and deeper molecular remission, as well as failure-free survival. This might be hard to see, I apologize, but if you move patients through an algorithm, first assessing their so-called risk, and then whether they have one of these variants, you can further clarify a newly diagnosed cohort of patients on imatinib into a very high and favorable and low and intermediate risk categories, which stratify very nicely with regards to the endpoints we're concerned about: early molecular response, failure-free survival, as well as molecular response. And on the right, you can see the predictive value of so-called score variants. These models, particularly categorizing patients sequentially, really have good power, and the progression to accelerated blast crisis based on so-called risk and versus the additional model there in the bottom are very predictive. So quite important also is that these variants, even in patients who do achieve early molecular remission, go on subsequently to be predictive whether they're going to have deeper molecular response over time. And if you look at very high-risk patients, there's quite a heightened risk of progression. Peripheral arterial disease with nilotinib, or peripheral arterial occlusive disease, rather. And this study from a Korean group showing changes in the ankle brachial index, which is quite an easy way to assess vascular disease in patients with both first-line and second-line nilotinib, having a significant minority of patients have change in this parameter. The clinical implications were also quite serious, with, as you can see, a number of patients requiring vascular intervention, even amputation in some cases based on this peripheral arterial occlusive disease development. So I think this led to further scrutiny. I think we saw as has been, I think Dr. Schiffer had pointed out, the difference in imatinib versus nilotinib in the NEST-ND trial. This is the 5-year snapshot of cardiovascular events, and we can see the difference, even the difference between the doses of nilotinib. So it's not a vast number of patients, but it's clearly a signal and clearly the difference between imatinib. And of course, we're all aware of ponatinib and cumulative events in both the phase 1 and the phase 2 studies quite high. So Mike Deininger shared this slide, which I think was appropriate to step back and say, what do we know about TKIs in general? And across the board, aside from imatinib, there seems to be a signal favoring that the second-generation TKIs do trigger changes that are associated with vascular occlusive events. And a second meta-analysis, I think, showed a similar pattern with a composite of arterial events. This is a very busy slide, but it was a bit more inclusive. With quite a strong signal for ponatinib and nilotinib, with a little less confidence around bosutinib at this point. With regards to mechanism of action, I understand this is from Peter Valence's group. I think this was just published literally in the last few days now. We finally have a little bit more clarity on, at least in their in vitro and animal models, about nilotinib and vascular endothelial changes. I think we see changes in proliferation. We see changes in the expression of endothelial markers, which probably gives us a good direction with regards to mechanism of action, although that doesn't really answer the story entirely. And in vascular tube formations and umbilical vein endothelial cells, you'll see sort of a similar anti-proliferative and pro-atherogenic effect with nilotinib versus imatinib. So I think this paper, again, is one of the earlier papers. There have been other looks. This is from the Italian group, looking at biomarkers, which would be another way to look at it in patients. And the lectin-like oxidized LDL receptor, or LOX1, seems to have a predictive value as a biomarker for patients treated with both imatinib and nilotinib. So this might give us a little direction with regards to how to prospectively look for risk. I think our problem has been we haven't been monitoring very well in our clinical trials. Not to be critical as part of this study, but in the PACE trial, the entry criteria were fairly bland. Of course, they tried to minimize some of the patients with the freshest cardiovascular events, but the monitoring, we had to look at triglycerides, EKGs, and echocardiograms. Echocardiograms are not very predictive of myocardial damage or risk of damage. It really just shows completed events. I think this is a vestige from our days of looking at trastuzumab-induced changes in breast cancer. So this may not have really been a fair assessment or predictive of changes. So we don't really have the answers yet, but I think we have some guidelines, and these are from something that will be published soon from Javed Moslehi and others, where we've kind of used his adaptive ABCDE approach, kind of be a good internist and look at your patient's cardiovascular risk factors, but then our best thoughts as to what we should be looking at prospectively in patients on TKIs. And it's different, as you can see, for nilotinib and ponatinib, and it's something you need to follow over time. But it's not complicated, and it can be done in cooperation between the internal medicine, cardiovascular teams, and the oncologist's office, but it's very important and requires your attention. I'm glad to say we're finally opening a study which is a prospective look at cardiovascular metabolic risk in newly diagnosed CML. This was Bristol Myers Squibb helped sponsor this, where patients initially diagnosed who are treated with any TKI, dealer's choice really, will then have a reasonable amount of cardiovascular and clinical assessments done, baseline, 3-month, 6-month, 24-month, to see if we could find biomarkers or predictability early. Do we see changes in clinical or different interventions over time, such as ankle brachial index and coronary calcium scoring, for example? So I think this is an important study. It's just begun to enroll and is available across the U.S. And I think will hopefully help us answer some questions, at least in a descriptive way, as we move forward with more trials and more questions.